All right, so I have no specific disclosures to make about any drug companies that pay me money, but I am partial to Far Side cartoons, so they might show up here and there. So headaches have plagued mankind for an awfully long time. We have evidence of trepanation, holes in the skull being made back in the Neolithic period. This is a skull from that period of time. We have evidence of prescriptions written on papyrus from the ancient Egyptians, and Hippocrates, who lived 470 to 410 BC, described a shining light in the eye followed by violent headache and vomiting, which sounds an awful lot like migraine. Headaches are one of the most common complaints seen by physicians. How many people here have headaches? Okay, I'm assuming that's what you're doing here. Despite the frequency of the condition and the disability that they cause, headaches are very underdiagnosed and undertreated. In terms of the lifetime prevalence, 78% of people will have tension headache at some point in their life. 16% will have migraine. Headaches associated with severe structural pathology are uncommon, less than 1% of all headaches. We classify headaches in several different ways, but we break it up into two primary categories. Primary headaches, those are the headaches that aren't really caused by anything specific. So those are our tension headaches, migraine headaches, cluster, and other primary headache disorder, cough headaches, syncope, micturition headaches, orgasmic headaches. Then there are the secondary headaches, those caused by trauma, vascular problems, non-vascular intracranial disorders like brain tumors, and other odd stuff. Every patient who comes in tends to think that their headache is due to one of these things: a big brain tumor or an aneurysm that's exploded. But keep in mind, about 0.5% of patients with headaches have a bad problem. Doesn't mean it's not functionally disabling, doesn't mean we can't make a diagnosis and treat it, but most patients don't have headaches that are medically dangerous. Now, what are the red flags? What do we look for? What should you be scared of if you get such a headache? The first onset of a severe headache, or the worst headache in your life, called a thunderclap headache. If you get a sudden headache, comes on like this, 10 out of 10, your job is to get yourself to an emergency room to make sure it's nothing important. The emergency room's job is to make sure you don't have an aneurysm that popped. If you walk into an ER and you tell them you are having the worst headache of your life, you will get a CAT scan. If your CAT scan is normal, you will get a spinal tap. If you don't want a spinal tap, don't say it's the worst headache of your life. Think about these things. New onset headaches after the age of 50, a little bit more bothersome, so we like to look into those. If headaches are constantly increasing in terms of frequency or severity, if you can't get them better with treatment, if they're always on the same side of your head, if headaches start after trauma, if you have systemic symptoms of a infection like fever or rash or a stiff neck, these are worrisome things. If you have seizures with your headaches, if you have a weird aura, and we're going to get to auras a little bit later, if your exam is abnormal, if you're immunocompromised, you're on chemotherapy, for example, or you've had a transplant and you're on medicines that knock down your immune system, those headaches are more significant because we're concerned that it can be a weird infection. Patients who have neurocutaneous disorders, things like neurofibromatosis, those patients are more prone to brain tumors, so we get a little bit concerned about their headaches. And headaches that come on or worsen if you cough or sneeze or exerting yourself or if you bend over. So what do I do when I see a patient? So the interview with the headache patient. Headache diagnosis is made primarily on the history. That's why it's so difficult. So we take a good medical history. I like to ask about asthma and high blood pressure because that's going to be implicated in treatment options, and we'll come to that down the line. I like to know family history. Migraines tend to run in families. If your mother, your aunt, your sister, and your daughter all have migraines, chances are your headache's a migraine too. What medicines are you taking? Do you take birth control pills? You're on hormone replacement therapy. What over-the-counter stuff are you taking? And psychological history plays in also. Are you depressed? Do you have trouble sleeping? Again, that's going to affect what medicines I recommend for headache management. Then we focus on the headache. What age did you start getting headaches? Migraines often start around the time of menarche, the time that girls start getting their periods. What are the initial symptoms? When people have headaches, migraine headaches for a long period of time, the migraine symptoms kind of fade, but if you go back to those original headaches, those will have those migraine characteristics. What medicines have been used? How'd you do with them? And what's the headache like? So before you see a doctor for a headache, think about it. What's my pain like? Is it tight and squeezy? Is it throbby and pulsatile? Is it a stabbing pain in the eye? Where is the pain? How long does it last? How often does it occur? What symptoms go with it? Are there any weird localizing symptoms? Do you lose your vision? Do you have trouble speaking? Do you get weak or numb on one side? How bad are the headaches to you? How much of an impact does it have? Do you need to limit your work schedule? Do you need to avoid doing social activities? That's a real problem. Even if it's not a brain tumor, that's a problem. I don't want you living your life that way. Have there been any recent changes in the headaches? And what medicines have you taken and how do they work? Okay, image or non-image. CTs and MRIs may be indicated in some patients. If they've got a weird headache pattern, if they've got a history of seizures, if they've got weird neurological symptoms or signs. That being said, most CT scans and MRIs in patients with a normal neurological examination and an absence of those red flags are a very low yield study. That being said, an MRI is a non-invasive, non-dangerous test. A normal MRI can be extremely reassuring, so I have a very low threshold to order a study. EEGs. EEGs are not helpful in headache diagnosis. All right, so let's go through our types of headaches. We're going to go through them. We'll concentrate on the ones that are a little bit more common. So here's a patient with a tension headache. Look at the furrowed brow. Look at the bitemporal location, squeezing. She's pressing on her temples with her hands. Tension headaches are the most common headache disorder, affecting about 60% of all people, and up to 80% of all women will have. Notice that there's more women in the room than men, because women tend to have more headaches. Men give the headaches, no offense. Usually these headaches are mild, self-limiting. We don't really know what caused them. And we call them tension headaches. We think that they're muscular tension headaches. But a lot of patients with muscle tension headaches don't really have palpable muscle tension or tenderness. So what are they like? Well, they usually last anywhere from 30 minutes to about a week at a time. They tend to be both sides. They're pressing or tight rather than boom, 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 throbbing. Patients will describe them feeling like their head's in a vice. Usually they're mild to moderately intense. They tend not to get worse if you move around. They're not associated with nausea or vomiting, sensitivity to light or noise, and there's no other underlying cause. Anybody heard of a trigeminal autonomic cephalgia?
No.
Yeah? Oh.
No.
Oh, no? Anybody think that they have cluster headaches? Oh, we got a cluster. Just because your headaches come in groups, like a cluster, does not mean they're cluster headaches. Cluster headaches are very specific type of headache patterns. They tend to be, they're one of the trigeminal autonomic cephalgias. What the heck does that mean? The trigeminal nerve is the sensory nerve to the face. Autonomic is your sweating, tearing functions. And cephalgia means you have head pain. These are short duration, one side of the head pains that usually have autonomic symptoms on the same side. So the eye can tear, the eye can get red, your nose can get stuffy on that side, run on that side. Sometimes the eyelid actually droops, sometimes it swells, and sometimes the pupil's a little bit smaller. These types of headaches are divided into specifics based on the duration, with cluster being the most common. And this is a patient who's having a cluster headache, and you can see the eyelid is droopy compared to that side. The pupil's a little bit smaller. There's actually swelling over the eyebrow, and she's tearing from that eye. Cluster headaches are sharp, boring, stabbing pain that's in or behind the eye. The Pain is severe but short, lasts for 15 to 80 minutes if you don't treat it. And by definition, you have to have one of the following things. The eye can be red, the eye can tear, the nasal passages on that side get congested or run, the eyelid swells, sometimes you get sweating in the forehead, and the eye can be smaller or droopy. If I get called to the ER to see a patient who's got a headache and they're pacing, that's probably a cluster headache. If they're lying still with their head under the covers, that's probably a migraine. There's a sense of restlessness and agitation that tends to come with cluster headaches. Cluster headaches often are periodic, so they come at the same time every day and often seasonal. So in the spring, every day at 5 o'clock, you get a horrible headache. We could treat them either by treating the acute headache or try to prevent the headaches. Oxygen delivered through nasal cannulas can be helpful. Some of the medicines we use for migraine can be helpful. And ideally, if people have prolonged clusters, we like to treat them with preventive therapy. And a calcium channel blocker like verapamil tends to be the most effective. Every once in a while we do a nerve block, so this is demonstrating the occipital nerve in the back, and they can get a lidocaine injection into that region, and that can be helpful for cluster. All right, so let's get to the meat of the matter, migraine. How many people have migraines here? Okay, we've got a bunch. So migraines are really common, chronic, incapacitating neurovascular disorder. It's characterized by attacks of severe headache, autonomic dysfunction, we'll get to the specifics in a second, and in some patient an aura that has localizing neurological symptoms. Migraine is incredibly underdiagnosed and undertreated. Most severe recurrent headaches are some form of migraine and respond to the medications we have for migraine. Migraine sufferers have been notable throughout history. We've got Caesar, we've got Elvis, Napoleon, Darwin, Freud, and this is a representation of Lewis Carroll and Alice in Wonderland. And if you remember the Alice in Wonderland stories, Alice grew and stretched and shrank. Some auras have that kind of stretching, weird distortion of sensation. And people think that that's what Lewis Carroll was inspired by when he wrote his stories. Migraine is incredibly under-recognized. We've got almost 28 million migraine sufferers in the United States. About 15 million people experience severe impairment of daily activities or even need bed rest for their headaches. And about half of the patients with migraine remain undiagnosed. About 14 to 15% of patients who meet the International Headache Society criteria for migraine receive a different diagnosis. They're told they have sinus headaches or tension-type headaches rather than migraine. If you're given the wrong diagnosis, you get the wrong treatment. So why is it so hard to make a diagnosis of migraine? Doctors are under more and more pressure to see more and more patients in a shorter period of time. So it's a limited time availability with the providers to describe the symptoms and allow the doctor to make an actual accurate diagnosis. A lot of my patients will come in and they say, oh, I don't have migraines, I have sinus headaches. Well, the vast majority of people who say they have sinus headache actually meet the criteria for migraine, and they probably actually have migraine headaches. Sinus headaches are uncommon unless you have an acute sinus infection. The majority of patients with migraines actually will report some sinus symptoms like stuffiness, runny nose, or both. But again, it's migraine, it's not sinus. Wrong diagnosis, wrong treatment, don't get better. The other diagnostic challenges are that it's really a clinical diagnosis. There's no test I can do to see if you have a migraine. It's not like I could do an MRI or an EEG and say, oh, you obviously have migraines. Symptoms vary from one attack to another. Diagnostic testing is usually not indicated or it's normal, so it doesn't help you. And the time to make the diagnosis is time consuming. In addition, patients often have more than one type of headache. And headache patients are often really unhappy and stressed out about it, and they have depression and anxiety and insomnia on top of that, and a lot of physicians are off put by that, and they say, you know, it's psychological. Migraine isn't a psychological problem. It's a physiological problem that we can treat. Migraines tend to start in adolescence, more common in women than in men. Most patients have 1 to 2 headaches per month, but 10% have weekly headaches. Most patients have headaches that last about 24 hours, but about a quarter will have attacks lasting 2 to 3 days. 5% of the general population have 18 days of migraine per year, and 1% of the population, 2.5 million people, have at least 1 day of migraine per week. Most patients who have migraines haven't seen a physician for headaches in the last year. Most haven't been diagnosed with migraines. They use over-the-counter medication rather than prescription medicines to treat their headaches. The World Health Organization rates severe migraine up there with quadriplegia, psychosis, and dementia as one of the most disabling chronic conditions. So how do we make the diagnosis? It's by history. You need to have 5 attacks lasting 4 to 72 hours. You can't really make a diagnosis of migraine on the first attack. That being said, you kind of can. You need to have 2 of the following. It should either be unilateral, so on one half of the head, a pulsatile boom, boom, boom quality as opposed to that tight squeezing quality, moderately severe in terms of intensity, and aggravated by routine exertion, going upstairs, downstairs. That's terrible for migraine patients. You need to have at least one of the following associated with it: nausea or vomiting, sensitivity to light and noise, and we want to rule out a secondary headache disorder. About a third of patients with migraine will have aura on some occasion. So the auras are often visual, and they could be anything from this fractured mirror appearance where the world kind of gets cracked. People get zigzag lines, fortification spectra, white dots, colored dots, all sorts of weird visual symptoms. Some people also will have sensory symptoms, so they get numb or tingly on one side of the body. Every once in a while someone will say that they get confused or have language dysfunction before their headache. Usually the aura comes before the headache and resolves as the headache starts up. If you say, I don't have migraines because I don't have an aura, you're going to miss the diagnosis. Only a third of patients will have aura. Vestibular migraine is another really hot topic. More patients who have migraines have vertigo. When you look at patients who have tension headache or patients without headaches, the co-occurrence of migraine and vertigo is over 2%. Many patients with migraines say they have a history of motion sickness. Vestibular migraine is a combination of headaches and vertigo. Vertigo is a spinning, dizzy sensation, usually induced by head motion, but not always. You can get dizziness and instability of gait that comes and goes for seconds to minutes, even days at a time. Patients with vestibular migraine have headache, have vertigo, but they don't necessarily come at the same time. And they just go from ENT to ENT to ENT, get meclizine and meclizine and meclizine, antivert, and they just don't get any better. We're not sure exactly what causes vestibular migraine, but treatment tends to be with prevention. So what is a migraine? It is a primary disorder of the brain. It is not caused by a primary blood vessel or vascular event. It's a neurovascular headache, a disorder in which neural events result in the dilatation or expansion of blood vessels, which in turn results in pain, further nerve activation, and it goes again and again and again. Migraine probably results from some sort of problem in the brainstem. Anytime you see a sentence from a physician that has dysfunction, diencephalon, nocioceptive modulation of craniovascular afferents, if you have that many words that are that many syllables in one sentence, we don't really understand what causes migraine. So what do we do for treatment? Patient education. There are lifestyle changes you can make that help avoid triggers. Regular sleep. The migraine brain likes a regular schedule. Go to bed the same time every night, Wake up the same time every day. Regular meals, don't skip meals, don't carb load, don't skip lunch and have a Snickers bar. Regular exercise, something aerobic a few times a week. Try to avoid peaks in stress and relaxation. A lot of teenagers will have that have migraines don't have their migraines during their exams. They get migraines as soon as the exams are over and they're ready to do vacation. Avoid dietary triggers. I'm not a huge believer in a migraine diet. There are books out on migraine diet. If you eliminate all of the foods that are suggested in these books, I don't actually know what's left to eat other than plain boiled chicken breast, maybe. Common triggers, watch for them. Chocolate, nuts, hard cheese, wine, especially red wine, artificial sweeteners, MSG and spicy foods, Chinese foods, soups. I don't care what they say at the restaurant, they don't take it out of the soup. Nitrites in prepared or smoked meats. Really common migraine triggers. Doesn't mean they're a trigger for you. It means you need to watch what you eat, and if you get a headache a couple of hours after you eat a chocolate bar, you probably got a chocolate trigger. Therapy is divided into the therapy for acute attacks and then preventive therapy. So for acute attacks, we say treat early and treat hard. So that means you want to get the medication in early and you want to take an adequate dose. So what do we give? Big whopping dose of aspirin, Tylenol, naproxen, or ibuprofen. Sometimes an anti-nausea drug or something like Reglan that helps move the stomach contents along can facilitate the absorption of the medication and be helpful for migraine treatment. That being said, you want to really be careful about analgesic overuse. Analgesic overuse can cause rebound headaches, constant headaches that can evolve into chronic daily headaches. In that setting, prophylactic agents aren't effective, and you just get worse and worse headache and an increasing reliance on your medication. We like to restrict our analgesics to 2 to 3 days a week. If you need medication for your headache more than that, chances are you need to be on a preventive agent. We'll go to that in a sec. When I tell patients to stop taking 4 Aleve, 6 Excedrin, 9 Advil every single day, chances are their headaches are going to worsen before they get better. A short course of steroids can be very helpful to make that transition. We do not like to give opioids. Tylenol with codeine, Vicodin, OxyContin, Percocet, any of those for headache treatment. They mask the pain. They don't really work on the pathophysiology of migraine. They can leave you cognitively impaired. There's certainly an addiction risk. And they really don't have any advantage over migraine-specific therapies. So what do we have that's migraine-specific? We have the triptans. Triptans are medicines that work on the serotonin receptors. Serotonin is the neurotransmitter that's implicated in the propagation of migraine. They're well-established, they have well-established efficacy and well-established safety. That means there have been numerous studies, controlled studies, that show that they work and show that they're safe. They have a mild to moderate side effect profile. A lot of patients will report that they get tingling, they feel warmth, they get flushing, they're dizzy. There could be some neck pain, some chest discomfort and stiffness. It usually passes in 5 to 10 minutes. They certainly cost more than our over-the-counter medications, and we can't use them in the setting of cardiovascular disease. So if you've had a stroke or a heart attack, or you have a lot of vascular risk factors, high blood pressure, diabetes, peripheral vascular disease, cholesterol, we don't like to use the triptans because they bring the blood vessels down, and hence they put you at increased risk for stroke or heart attack in the right setting. We have 6 different triptans that are available. Some are in pill form, some are in melting tabs, some have a nasal spray that you can use, and some you could use by injection. Different strokes for different folks. I tend to start with one of the generic triptans, see how it goes. I usually use a moderate dose, so like sumatriptan, which is the first developed one. has a generic. Imitrex is the brand name, sumatriptan is the generic name. It comes in a 25, a 50, and a 100 milligram pill. I tend to start with the 50s unless I have a person who's really tough, and then I'll give them the hundreds. For my patients who get a lot of nausea and they can't swallow pills, Maxalt over here, Maxalt or rizatriptan, has a melting tab. So does Zomig. Imitrex and Zomig both have nasal spray components. So it really depends on the situation, but there are a lot of options out there. If one triptan doesn't work, doesn't mean the other ones won't. So it's a little trial and error. When do you use preventive therapies? When migraine sufficiently interferes with your daily routines despite having acute treatment. When the acute medications fail or you can't use them or they cause too many side effects. When you overuse the acute medications. In certain specialized migraines like hemiplegic migraines, so migraines that are associated with weakness on one side of the body. Or frequent headaches. Now, frequent is a kind of fluid term. I usually use the 2 headaches per week rule. If someone's having 2 significant headaches per week, I really talk to them about preventive therapy. And some patients would just prefer to go on preventive therapy. There are no medications that are specifically designed for migraine prevention. We steal them from our colleagues in other subspecialties. So we have seizure medicines, we have antidepressant medicines, we have beta blockers and calcium channel blockers. So we steal medicines from our colleagues who treat seizures, treat depression, and treat cardiac disease. Unlike treating an acute headache where you start quickly and you go hit it hard, with prevention, you start low and you go slow. For that reason, it takes a little time to kick in, but the side effects tend to be better if you start with the medication relatively low. About 2/3 of the patients are going to have a 50% reduction in migraine attacks. How does it work? It modifies brain chemistry and brain sensitivity. I don't think we know specifically how all of these different medicines work specifically to prevent migraine. There are several well-proven and well-accepted medications that we use for migraine prevention. Amitriptyline or Elavil is one of the old antidepressant medications. It's a sedating antidepressant. It tends to be really good for my patients who have trouble with sleep as well as with migraine. We use a dose starting with 25 milligrams. I often start even lower with 10. And I find that if I'm not getting an effect by 50 milligrams, I usually stop it. Give it all at bedtime because it can make you a little drowsy. People often get dry mouth on the medicine, and constipation is really common. Pamelor, or nortriptyline, which is a cousin of Elavil, usually is better tolerated. It just hasn't been studied as well. I tend to be a Pamelor girl rather than an Elavil girl. Depakote is one of our anticonvulsant medications. Can be very effective for migraine prevention. Problem is the side effect profile. People get drowsy, they gain weight, they get tremulous, they lose the hair on their head, they get hair on their face. It can cause fetal abnormalities, and you have to monitor blood count and liver profiles. Most of my migraine patients are women. Most of my women don't like to be fat and hairy. I tend not to use Depakote as my first line choice. Topamax, on the other hand, unlike most of the other medicines we have for migraine prevention, actually causes a little bit of weight loss. It's another seizure medication, tends to be well tolerated, but it does have a reputation on the street of being called Dopamax. Some people get a little forgetful on the medication, some people have some word finding difficulties, and some people can get a little moody or depressed on the medicine, so you have to be careful of that. Commonly, people will get tingling in their fingers and toes when they start on Topamax. So I need to warn people about that. There are a lot of medicines that are very commonly used, but they haven't been studied as well. Verapamil, one of our cardiac medicines, is a calcium channel blocker. Again, tends to be well tolerated, but drops people's blood pressure, so you can't use it in people who have low blood pressure. Also, if you have a problem with your heart rhythm, not a good medicine for you. Can be associated with some constipation. People often get edema in their legs or leg swelling, so you have to be a little cautious. Some of the other antidepressant medications, the SSRIs like Prozac and Zoloft and Paxil, can be helpful. I find that they actually tend to make headaches worse rather than better, so not one of the ones I run to right away. Gabapentin or Neurontin, one of my favorite medicines. Tends to be helpful for muscle tension headache as well as migraine, really well tolerated, doesn't interact with other medicines. So my patients who are on a bunch of medicines and have migraines, that's one of the ones I use. Also, I find it dampens down anxiety, helps with sleep, can be really, really well tolerated. People will get a little tired with it, and sometimes people get dizziness. But if you start low, it's usually good. There are behavioral and physical treatments that we can use as well. Some patients really like to do things like acupuncture, physical therapy, therapeutic touch, and I'm happy to use integrative medicine techniques in my practice. Some patients just prefer it. Some people are extremely poorly tolerant of medications, or they're on so many medicines or have so many other medical problems that you just can't use medicines. Or if they just don't do well with medication. Obviously, if people are pregnant, planning pregnancy, or nursing, we really like to avoid medication. Also, if they have a history of really overusing their acute treatments, I like to introduce some kind of behavioral therapy. It's also really helpful for my patients who are highly stressed and have poor coping skills. That can really be helpful. Relaxation therapy or hypnotherapy, cognitive behavioral therapy, and some of the physical therapies like acupuncture and TENS. There's now a unit called a Cephaly device. Anybody heard of a Cephaly device? Yeah. You can get it on Amazon. It's a TENS unit that wraps around your head. TENS gives you little pulses of electricity, and it's been shown to be helpful for chronic migraine. Some people have a lot of teeth grinding, so sending them to the dentist for a bite plate can be helpful. Cervical physical therapy, stretch can be really helpful. Not a big believer in chiropractic manipulation. There are blood vessels that run in your vertebral bones, called the vertebral arteries. They take blood to your brain. If a chiropractor does a quick adjustment of your neck, those blood vessels can be injured and cause a stroke. Sometimes we do occipital nerve blocks. I showed you that with the cluster headache treatment. And people who have a lot of tension in their neck, sometimes trigger point injections can be helpful. Botox. Anybody getting Botox for their migraines? Okay. Botulinum toxin impairs the release of acetylcholine at the peripheral synapses. Okay. Acetylcholine is the neurotransmitter that allows the nerves to talk to the muscles. The synapse is the connection between the nerve and the muscle. It causes weakness of smooth muscles and striated muscles, so both voluntary and involuntary muscles. We've used it for a long time for a variety of things. Strabismus, which is lazy eye, dystonia, sustained abnormal muscle postures, and for reasons that are not entirely clear, it's helpful for migraine. It makes sense to me that Botox would be helpful for chronic muscle tension headaches. No, it's helpful for migraine. We don't really know how it works. People who have occasional migraines are not Botox candidates. In order to get insurance approval, you need to qualify by having 15 days of headache per month, headaches that last for more than 4 hours a day, and you need to actually fail 3 other categories of medication before the insurance will approve it. And Botox, if anybody goes for wrinkles, is expensive. So if you don't have insurance authorization, it's a problem. And this is a photo of somebody getting Botox injections. They use 30 to 40 little injection sites around the forehead, between the eyes, around the ear, and back of the neck and shoulders. A lot of my patients don't like to take prescription medicines, but they really like over-the-counter supplements. And there are a number of different supplements that have been shown in controlled studies to be helpful for migraine prevention. Magnesium, it's just a mineral supplement. Riboflavin, or vitamin B2. Feverfew, butterbur, and coenzyme Q10. So magnesium, just one of the mineral elements. Helpful for a lot of different symptoms, including muscle cramps. We use it in women who have eclampsia and seizure disorders. Can be really well tolerated. The downside of magnesium is the active ingredient in milk of magnesia. So loose bowel movements. Most of my migraineurs tend to be on the constipated side, so it's a win-win for all of us. That being said, I've had some patients take magnesium, get diarrhea, freak out, get colonoscopies when it's really just the magnesium. Riboflavins, so there's our vitamin B2. There's Feverfew, it's part of the daisy family. It's just an herb, tends to be really well tolerated. Vitamin B2, no side effects. Urine will turn bright yellow or bright orange. And CoQ10 is a antioxidant over the counter, tends to be really well tolerated. Some people will get some belly upset, but usually well tolerated. Butterbur is another herb that's helpful for migraine prevention. It's been used since the 50s. All right, we're leaving migraine. We're going on to cervicogenic headaches. Cervicogenic headaches are headaches that are caused by pathology in your neck. So you get referred pain that's perceived in the head that comes from a source in the upper cervical spine. It means your problems in your neck can actually cause headaches. The nerves that are in the tissues and bones of the neck have branches that travel to the skull and the scalp, and that's what causes these cervicogenic headaches. They tend to start in the neck and shoulders and the back of the head, but they can travel anteriorly over the top of the head and even into the temples. They tend to be worse with neck movement or positioning. So these are my patients who get headaches when they're looking down like that or when they're looking up like that, and I can feel on exam that they've got tightness in the back of the head and neck and shoulders, and they have restriction in terms of range of motion. They range from mild to severe. Usually these headaches don't have associated features like sensitivity to light or noise or nausea or vomiting. In terms of treatment for this, a lot of the medications we use for migraine, specifically the antidepressants like nortriptyline and gabapentin, one of our seizure medicines, really helpful. These headaches often respond to physical therapy, acupuncture, and sometimes occipital nerve blocks or trigger point injections. Giant cell or temporal arteritis is an unusual headache syndrome, but something you need to be aware of, especially in the older patient population. Patients over 50 are more prone to this condition. Relatively uncommon, a little bit more common in women, and more common in patients who have other rheumatological disorders like polymyalgia rheumatica. In this condition, you get a one side of the head headache, so a unilateral headache, and the artery at the side of the head, the temporal artery, becomes swollen and tender. You can see this artery here, and the scalp actually looks like that. The reason these headaches are important is because the same blood vessels that are over here are connected to the blood vessels that take blood to the back of the eye. So left untreated, this condition can actually cause visual loss or blindness. So when I see an older patient who's coming in with one side of the head headaches, I always want to ask them, does it hurt when you chew? Does your jaw get tired when you chew and hang open? If you're chewing, does your tongue get numb or heavy or thick? Because those are signs of temporal arteritis. We usually make the diagnosis by laboratory studies, so there are 2 inflammatory markers that we check, so that's a simple blood test. And if we're not sure, we actually go to a biopsy, and it's a relatively simple procedure to do a biopsy of the temporal arteries. That's done usually by one of the plastic surgeons, vascular surgeons, or some of the ophthalmic surgeons. And the artery looks inflamed, thickened, and swollen. The treatment is corticosteroids, so a high dose of prednisone that's gradually tapered over time. Usually, these headaches will respond to steroids in a day or 2. In conclusion, we've got headaches. It's a common disabling condition. It's often underdiagnosed and undertreated. We have a ton of effective therapies for both acute treatment and for prevention. Patient and practitioner education is really essential to therapy. Thank you. Are there questions? Yes. Yes, you.
So I asked you earlier just if you have your opinion on that. I was in a car accident 2 years ago.